Hi everyone, I am Dr. Sneh Verma, Leader, School of Dental Sciences, BBD University. In today's video lecture, we are going to talk about the normal occlusion. So, in dentistry, occlusion refers to the relationship of maxillary and mandibular teeth when they are in functional contact during activity of the mandible. The alignment and occlusion of the dentition are extremely important for the masticatory function. The basic activities of chewing, swallowing, speaking all depend not only on the position of the teeth in the dental arches, but also on the relationship of opposing teeth as they are brought into the occlusion. So, occlusion is defined as the manner in which the upper and lower teeth intercuspate between the each other in all mandibular positions and movements. What is occlusion? It was rightly defined by the Remford and Ash as it is the medium that brings all branches of dentistry together. So it is a Latin word which means closing up. Occlusion, that is closing, and oc means up, closing up. It may be defined as the contact relationship of the teeth in function or parafunction. Can also be referred to the relationship of the maxillary and mandibular teeth when they are in functional contact during activity of mandible. Shaw defined dental occlusion as the static closed contacting position of the upper teeth to the lower teeth. So these are the various definitions, simpler definitions given by the different authors. The most comprehensive definition was given by the Jablonski, which includes all the things together as a whole, and it is defined that occlusion is the relationship between all components of the masticatory system in normal function, parafunction, and dysfunction, including the morphology and functional features of the contacting surfaces of the opposing teeth and restoration. So all the component of the stomatognathtic system, all the functions of the mandible, and the relationship of individual teeth to one another within the jaw and between the jaws, all these things come together within this definition. So occlusion is the result of neuromuscular control of the components of the masticatory system, which includes teeth, periodontal structures, and the maxilla, mandible, TMJ, and their associated muscles and ligaments. All these components makes the occlusion to be functional. So occlusion has both the static and dynamic aspects. As static refers to the form, alignment, and articulation of teeth within and between the arches, okay, and the relationship of teeth and their supporting structures, that is anatomical aspects of the occlusion is there. But usually the classification of malocclusion is done on the basis of static occlusion itself, because it deals with the teeth and other related structures. But what is dynamic aspect of occlusion? Dynamic refers to the functional aspect of the stomatognathtic system as a whole, comprising the dentition, supporting structures, TMJ, neuromuscular system. So we can say occlusion when jaws in are motion, that is the dynamic occlusion, and the occlusion that is related with the relationship of teeth to each other and their muscles is a static occlusion. So it was Edward H. Engel who described the 4 classes of occlusion. One is a normal occlusion, which was later on, which was 6 keys to occlusion was given by the Andrews, and class 1 malocclusion, class 2 malocclusion, class 3 malocclusion. It was the normal occlusion, which was referred orthodontically by Engel, was the when mesiobuccal cusp of the maxillary molar, here mesiobuccal cusp of the maxillary molar uh, occludes in the um, mesiobuccal developmental groove of the mandibulary first permanent molar. So the key to occlusion was the maxillary first molar. Coming to the intra-arch tooth alignment. As we talked about, the occlusion is the completeness of all the things, teeth, their inter-arch, intra-arch relation. So first we discuss about the intra-arch tooth alignment. How the teeth should be there within the arch. So intra-arch tooth alignment refers to the relationship of the teeth to each other. So in this, we have various planes of occlusion. So plane of occlusion refers to the imaginary surface that theoretically touches the incisal edges of the incisors and tips of the occluding surfaces of the posterior teeth. So this is plane of occlusion, which touches the incisal edges of the incisors from anterior side and posteriorly tip of the occluding surfaces of the posterior teeth. It refers to the plane of occlusion. What is the significance of this? Mandibular movements are determined by the two TMJ joints and which rarely function with identical simultaneous movements. Since most jaw movements are very complex, with the center of rotation constantly shifting, a flat occlusal plane will not permit simultaneous functional contact in more than one area of the dental arch. Therefore, the occlusal planes of dental arch are curved in a manner that permits maximum utilization of tooth contacts during function. So, in this intra-arch tooth alignment, we have mesiodistal axial inclinations. If lines are extended through the crowns, the angulation of the teeth with respect to the alveolar bone can be observed. As we can see in these figures, these lines, these long axis of the crowns of all the teeth are not in a straight vertical line. They are angulated in mesial direction, in any direction. So there is a mesially direction. So inclination of teeth in the mandibular arch, both the anterior and posterior teeth are mesially inclined here. The second and third molar are more inclined than the premolars, as we can see here. But in the maxillary arch, you can see the anterior teeth are generally mesially inclined, with the most posterior molars being distally inclined. Somewhat distal inclination would be there in the maxillary posterior teeth. So depending on this mesodistal angulation of the teeth, we can describe different compensating curvatures. The first, the curvature, the curve of Spee, it refers to the anterior-posterior curvature of the occlusal surfaces, and it begins from the tip of the lower cuspid, then progresses to the premolars and molars, and continuing to the anterior border of the ramus. And if this curved line continued further back, it would follow an arc through the condyle. You can see here the curve starting from the canine tip and progressing backwards and passing back through the condyle. The curvature of this arc would relate an average a part of a circle with a 4-inch radius. So this is a compensating curvature given by F. Grons P, so named as curve of Spee. It results in alignment of each tooth for maximum resistance to the functional loading. The long axis of each lower tooth is aligned nearly parallel to the individual arc of closure around the condylar axis. As in previous picture, we have seen the arc produced by this mandibular tooth alignment. This progression positions the cusp tip on the curve that is directly related to the condylar axis by a progressive series of tangents, and it is a curve which displays in the sagittal plane or anteroposterior curvature. Then the relationship of the curve of P to the condylar axis also relates to condylar path of protrusion. In the occlusal plane is on the arc that passes through the condyle. The posterior part of the occlusal plane will always be flat enough to be discluded by the normal condylar path on its steeper eminentia. Thus, even with the flat 0-degree anterior guidance, the occlusal plane on the lower will be discluded by the forward movement of the condyle that is directed downward at an angle that is steeper than the posterior part of the occlusal plane. Then coming to the buccolingual axial inclination, when we observe the dental arches from in the front view, we can see the buccolingual axial inclination. In the maxillary arch, the posterior teeth have a slight buccal inclination, and the anterior teeth also has a labial inclination in the maxillary arch. Whereas in the mandibular arch, we can see all the teeth have slightly lingual inclination. Based on this buccolingual inclination, there is a compensating curvature known as a curve of Wilson. It is a mediolateral curve. It contacts the buccal and lingual cusp tips on each side of the arch. And this, as I said, it results from inward inclination of the lower posterior teeth, making the lingual cusp lower than the buccal cusp on the from the mandibular cusp. And how it helps? It makes the teeth alignment parallel to the pull-off direction of medial pterygoid muscle, and that provides a optimum resistance to masticatory forces. And aligning both the upper and lower posterior teeth with principal direction of muscle contraction produces the greatest resistance to the masticatory forces and creates the inclination that forms the curve of Wilson. Here, this is the curve of Wilson, and this is the lateral pterygoid muscle. So, alignment of posterior teeth will parallel to the direction of loading from the internal pterygoid muscles results in curve of Wilson. And also, the elevated buccal cusp prevent the slippage of the food from the occlusal table during the mastication. Here, the inward inclination of the lower occlusal table is such that is designed for direct access of food from the lingual and with no blockage by lower cusp by the action of the tongue. And the outward inclination of the upper occlusal table provides assist from the buccal for the food to be tossed directly on the occlusal table by the action of the buccinator muscle. Coming to the Bonville triangle, defined by the Bonville, who was the first to describe the dental arches, and he noted that an equilateral triangle of 4 inches existed between the center of the condyles and the mesial contact area of mandibular center incisors. Then one more compensatory curve of Monson. It is a lateral curve, and this is a 3-dimensional combination of the curve of P and Wilson. According to Monson, who introduced this cusp, that all cusp and incisal edges in the natural dentition are tangent to the surfaces of a sphere, which is approximately 4 inches in radius. that is 10.2 centimeters, with its center in the area of the glabella. So the curve usually does not exceed 5 to 10 degrees from the horizontal plane of orientation when viewed in the frontal plane. So the curve of Monson is obtained by extending the curve of P, this curve of P, and this is curve of Wilson to all cusp and incisal edges. Coming to the relationship of teeth within the arches, that is overbite and overjet. Overbite is the vertical relationship of the upper teeth to the lower teeth in the centric occlusion, whereas overjet is the horizontal relationship. Sorry, this is overjet and overbite. Overjet is the horizontal relationship of the upper teeth to the lower teeth in the centric occlusion. Overbite enables the disclusion of the posterior teeth during food incision and increases the efficiency of the anterior teeth in biting, whereas overjet increases the duration of occlusal contact in protrusive and lateral movements in incising and mastication. So, in the interarch tooth alignment, as we have seen the overjet on overbite, it refers to the relationship of teeth in one arch to those in the other. When the two arches comes into the contact, as in mandibular closure, the occlusal relationship of the teeth is established. In this, we have the arch length. In normal interarch relation, both the arches have approximately the same length, but the mandibular arch being only slightly smaller, as maxillary arch is about 128 millimeter, whereas the mandibular arch being 126 millimeters. The slight difference is a result of the narrower mesodistal distance of the mandibular incisors as compared to the maxillary incisor. And in normal relation, the mandibular arch is again slightly less than maxillary arch, and so when the arches occlude, each maxillary tooth is more facially positioned. This occlusal relation protects the surrounding soft tissues from trauma from mastication. So, buccolingual occlusal contact relation. If an imaginary line is extended through all the buccal cusp tip of the mandibular posterior teeth, the bucco-occlusal line is established. In normal arch, this line flows smoothly and continuously, revealing the general arch form. In maxillary arch, if this line extends through the lingual cusp of the maxillary posterior teeth, the linguo-occlusal line is observed, and this line reveals general arch form of the maxillary arch. And then a third imaginary line can be drawn through the central developmental groove of the maxillary and mandibular posterior teeth. The central fossa line is established. The proximal contact areas are placed slightly buccal to the central fossa line. In normal bucco-occlusal relationships of the posterior teeth in occlusion, the bucco-occlusal line of the mandibular teeth occludes within the central fossa of the maxillary teeth here. Simultaneously, the linguo-occlusal line of the maxillary teeth occludes within the central fossa of the mandibular teeth. Mesodistal occlusal contact relationship. So, occlusal contacts occur when the centric cusp contacts the opposing central fossa line. These cusps typically contact in one or two areas: central fossa and areas, and the marginal ridge and embrasure areas. So you can say it's a cusp to fossa contact and cusp to ridge contacts. So before going to this we know some centric contacts. They are the areas of the teeth that contacts the opposing teeth in centric occlusion. So they are the point contacts and have been classified as posterior centric contacts and anterior centric contacts. So posterior centric contacts are when the cusp tips occlude in the corresponding opposite centric fossa and marginal ridges of the opposing arch. This arrangement helps in the transmission of the forces along the long axis of the teeth. And anterior teeth have their centric contacts in the lingual fossa region and are in the line with the facial range of posterior centric contacts. So centric contacts often occur on inclines of the posterior teeth. So cusp to fossa occlusion is a type of occlusion when the stamp cusp of one tooth occludes in the single fossa of its opponent. The upper stamp cusp fit into, here we can see the upper stamp cusp fit all in the lower teeth except while the lower stamp cusp fit into all upper fossa except the distal one of the bicuspids. This kind of arrangement where contacts occur between single opposing teeth is called a cusp fossa occlusion. Next one is the cusp embrasure occlusion, where the upper and lower teeth are called as cusp embrasure or two teeth occlusion. Here each tooth occludes with two opposing teeth to its side. It's like you can see this maxillary first premolar, if it will have this lingual cusp have in contact with both the premolars. So this is tooth to tooth occlusion or cusp embrasure occlusion. Cusp fossa relationship gives the advantage of forces being directed along the long axis of the tooth, greater stability to entire arch of teeth, and less of a tendency towards tooth movement. And there is a less chance of food impaction between the embrasures. Here we can see in normal interarch tooth relationship, each tooth occludes with two opposing teeth like this. This teeth have two opposing teeth, this teeth had two opposing. The mandibular central incisor and the maxillary third molars are exception because they have only one opposing teeth. Significance of cusp one tooth to two cusp occlusal relationship is it helps to distribute occlusal forces through several teeth and ultimately over the entire arch. It also helps to maintain some arch integrity even when tooth is lost, since stabilization, the occlusal contacts are still maintained on all the remaining teeth. Because they have two teeth in the opposing arch to contact, if one is lost, the another is there to maintain the vertical relationship with the arch. What are centric stops? When the teeth are in centric occlusion, they should have maximal interdigitation with locking of the two arch positions. The three areas of centric contacts or centric stops between the two arches are height of cusp contour, marginal ridges, and the central fossa. Those cusps that function during centric occlusion are called the supporting cusp. The position of the centric stops helps to determine the height of the lower 1/3 of the vertical dimension of the face when the teeth are in centric occlusion. These contact relationships change with wear of dentition. This process of attrition develops numerous flat surfaces resulting into the loss of a definite locking of two jaws in centric occlusion. Centric relation, coming to the centric relation, is a gnatological term, refers to the positional relationship of the TMJ joints. So it is an axial position, meaning the joints can rotate to open or close the jaws without moving of the centric relation position, and so the mandible can be in centric relation even when the teeth are separated. So it can be defined as a relation of maxilla to mandible to the maxilla when the mandible is in its most retruded, unstrained position from which lateral movements can be performed at any given degree of jaw separation. Is also termed as a ligamentous position. It is determined by the ligaments of the joints. So centric relation is a bone-to-bone relation. In this relationship, both the condyles are simultaneously seated most superiorly and posteriorly in this glenoid fossa. Condyles in the rearmost uppermost midpoint in the glenoid fossa, and more simply we may define as the it is a physiologic centering of the condyle in the cranium. So in centered position there is an absence of translation, and it is a muscle determined position, also called as retruded contact position. The maxillomandibular relation in which the condyles articulate with the thinnest avascular portion of their disc with the disc condyle complex in the anterior superior position against the slope of the articular eminence. This definition was given by Glossary of Orthodontics. Also defined as the relationship of the mandible to the maxilla when the properly aligned condyle disc assemblies are in the most superior position against the eminence, irrespective of tooth position or vertical position. To develop a harmonious occlusal relationship, if the condyles are not in correct position when our occlusion is altered, the occlusion will be harmonized to mal-related condyle position. Thus, the correctness of any occlusal treatment is dependent on where the TMJ is positioned. The diagnosis of TMJ disorders require accuracy in determining the central relation. So this is the important aspect. Diagnosis and treatment planning should be performed by an evaluation of the occlusion with mandible and centric relation itself, that is the natural musculoskeletal position of the condyle in the fossa, in order to obtain the true maxillary mandibular skeletal and dental relationship in the three planes of space. This is the mandatory aspect for diagnosis and treatment planning. Coming to the centric occlusion, it is a tooth-to-tooth relation. It is a habitual occlusion and the voluntary position of the dentition that allows the maximum contact when the teeth occlude. And it is related to the functioning of the dentition. It is also called as intercuspal position or convenience occlusion. In the individuals with occlusal interferences on the posterior teeth, the teeth deflects to the centric occlusion and closure of the mandible, which is known as centric slide. Centric slide can be considered a functional malocclusion because the posterior teeth are guiding directional tooth movements. The mandible is a suspensory system, but occlusal interferences make it a part of lever system. This causes excess occlusal forces causing injury to the tissue of stomatognathic system, and that is an undesirable aspect. In these cases, with major restorative work or dysfunction in the gnathosomatic system, it is desirable to fabricate a centric relation and centric occlusion coinciding, thereby eliminating the possibility of producing occlusal interferences that would stress the system and impede its healthy functioning. Common occlusal relationship of coming to the posterior teeth. As Engels had described the classification into three broad categories, class 1, 2, 3. So in the class 1, as already spoken about, when the mesobuccal cusp of the mandibular first molar occlude in the embrasure area between the maxillary second premolar and the first molar, and the mesobuccal cusp of the maxillary first molar aligned directly over the buccal groove of the mandibular first molar, the mesolingual cusp of the maxillary central line in the central fossa of the mandibular first molar. So this all will constitute the class 1 molar relationship. In this relationship, each mandibular tooth occludes with its counterpart and its adjacent mesial teeth. Class 2, whereas here mesiobuccal cusp of the mandibular first molar align with the buccal groove of the maxillary first molar. Class 2 was divided into two further segments, Class 2, Division 1 and Division 2. In Division 1, along with the Class 2 molar relation, there is the maxillary incisor teeth which are in labioversion. Whereas in Class 2 Division 2, typical Class 2 molar relation and the maxillary incisors are near normal anteroposteriorly or slightly in linguoversion, whereas the maxillary lateral incisors are tipped labially. The another thing can be there, all the four incisors are in linguoversion and the canine are tipped labially. Class 2 subdivision is the classification when the class 2 molar relationship occurs on one side of the dental arch and the other side is the class 1 molar relationship. The malocclusion is referred to as the subdivision of its division. Class 3 malocclusion refers when the distrobuccal cusp of the mandibular first molar is occluding in the embrasure between the maxillary second premolar and the first molar. The mesobuccal cusp of the maxillary first molar is situated over the embrasure between the mandibular first and second molar. Here, the mesiolingual cusp of the maxillary first molar is situated in the mesial pit of the mandibular second molar. Pseudo class 3 malocclusion, we can say it's not a true class 3, but presentation is similar. Here, this is due to the mandibular shift anteriorly in the glenoid fossa due to some premature contacts of the teeth or some other region when jaws are brought together in the centric occlusion. So, for the anterior teeth, there are some common occlusal relationship which we known as the canine relation and the incisor relationship. So this we can define as an incisor relationship into class 1, class 2 div 1 and class 2 div 2, and similarly class 3 anterior bite. So here in the class 1, the incisal edges of the lower anterior teeth are in relation to the anterior to the cingulum plateau of the upper anterior teeth, whereas in class 2 div 1 they are crossing the cingulum plateau and far ahead from this. In class 2 div 2 they are lower incisor edge mandibular incisors are in contact with the lingual aspect of the mandibular incisors. In class 3, the lower incisors tip can be in H2S relation or in a labial position to the upper incisors. And anterior open bite cases, there is no contact of the upper incisors edges and lower incisor edges. Canine relationship can also be classified into the class 1, class 2, class 3 canine relationship. So, in a class 1 canine relationship, the mesial ridge of the maxillary canine is in contact with the distal marginal ridge of the mandibular canine. Whereas in the class 2, distal marginal ridge of the maxillary canine is in contact with the mesial marginal ridge of the maxillary canine. And in class 3, they are mandibular arches put forward, so there is no relation. Factors and forces that determine the tooth position. The alignment of the dentition in the dental arches occurs as a result of complex multidirectional forces acting on the teeth during and after eruption. As the teeth erupts, they are directed into a position where opposing forces are in equilibrium. So, musculature, labial to the teeth are the lips and cheeks that provide relatively light but constant lingually directed force. Whereas on the opposite side, the tongue, which provides labial and buccally directed force to the lingual surfaces of the teeth. So all these forces should be in harmony. So neutral space is the position where labiolingual and buccolingual forces are in equilibrium. Coming to the proximal contacts between adjacent teeth, These contacts help to maintain the teeth in normal arch alignment. Occlusal contacts prevent the extrusion or supraeruption of teeth, thus maintaining the arch stability. If the tooth is lost, not only will the distal tooth likely to move easily, but the unopposed tooth also will likely to erupt. Then coming to the 6 keys of optimal occlusion, which was given by Andrews, and these keys will be dealt in detail in another video. So these are the individual keys are not entirely new, but together they have special values. They can be judged from tangible landmarks and from the facial and occlusal surface of the crown, and these are the keys on which we judge the optimicity of the occlusion. These are the keys: molar interarch relation, mesodistal crown angulation, labial-ungual crown inclination, absence of rotation, tight contacts, and curve of spee. It will be further taken up in the another lecture. So criteria for good occlusion includes 2 complete arches of teeth with secure contact points and occlusal surface contours adequate for the functions required, root shape and alignment adequate to resist occlusal forces, and rest position stable with adequate lip seal. An interocclusal distance of 2 to 4 mm between rest position and intercuspal position. Simultaneous and bilateral occlusion between all teeth of maxillary and mandibular arches at intercuspal position. No deflective contacts should be there. Cusp fossa and cusp ridge occlusion having tripod contacts. Return of each tooth to its original position on removal of the occlusal forces should be there. Articulation between retruded and intercuspal positions free from any interference causing lateral deflection. Stable vertical and horizontal overlap, empty mouth articular movements free from diffractive contacts. So these were the features that should be there in the normal occlusion. So thank you for your patient hearing. I hope you have understood something about the normal occlusion. Thank you.